Good morning, everyone. I'm delighted to introduce Dr. Jared Bunch from the University of Utah, where he holds the Nugent Endowed Chair and is the Associate Chief of Cardiovascular Medicine. Dr. Bunch did his undergraduate at Utah State. He went on to the University of Utah for medical school, and he did his cardiology and electrophysiology training at Mayo Clinic. He has been an active investigator in many areas of clinical electrophysiology, but he's particularly recognized for his work in the area of atrial fibrillation, stroke, and dementia. So we're delighted to have you. Welcome.
It's okay. Thank you for that kind invitation and more for the opportunity to spend this morning with you. And it's always a pleasure to be in the place where Mark Josephson was that changed so much of our careers in electrophysiology. And I had the great pleasure for Peter to come to do our grand rounds. And I have to he did such a good job. I have hope to return a little bit of the favor here with you today and talk about kind of a journey, a little bit of how we discovered this and where we're going, and also to invite collaboration and your own investigation into this area. We're learning, and we continue to learn each day, and I'll share you some of the things that really are changing how we're thinking about how we manage atrial fibrillation with some recent discoveries. If I can get this. These are disclosures. I don't receive any personal compensation, but they're relevant in the sense these people have interest in detection and management of atrial fibrillation and some of the therapies that we'll discuss, but there won't be any unlabeled or unapproved use discussed. Well, atrial fibrillation, as you know, we're passionate about it in electrophysiology, and this is recent data from Dominique Lenz showing that it's growing exponentially. And the most recent world estimate is 59 million of detected, and this remains stable if you look per 100,000 people, and also, which is interesting, in an aging population, if you account for age, it's almost doubling. And when we think about atrial fibrillation, we think about its adverse outcomes, foremost stroke, next heart failure, but also mortality. And when you're diagnosed with atrial fibrillation, you're put on this heightened mortality curve that's similar to many of the cancers that we treat. And when we think about mortality and what drives it, cardiovascular and cerebral vascular become central. And that can be stroke, dementia, cognitive decline. We'll talk about the latter here, but also heart failure, cardiomyopathy, microvascular dysfunction, but also non-cardiovascular causes. And I think these are intriguing because they speak to the systemic nature of atrial fibrillation. But patients with fibrillation have more cancer, frailty to thrive, failure to thrive, respiratory diseases, respiratory failure. They have more diabetic endocrinopathies, and they have more renal insufficiency and renal failure. So when you look at cardiovascular causes, it's about 40% of people. And exploring this, and there's the interlinks to it, gave us opportunities to understand atrial fibrillation and opportunities to intervene and perhaps alter some of these trajectories. But I've used brain as a surrogate for this, and there's a broad spectrum of injury. And we know for a long time that atrial fibrillation is associated with clinical strokes. We're learning more about the role of micro bleeds and microinfarcts. A lot recently about the role of cerebral hypotension and perfusion, and then how these interact with that gradual atrophy, volume loss, white matter changes, amyloid plaques. What we do know with it is it begins early, injury to the brain. And if you take the same markers that they use in the NFL and that cross the blood-brain barrier with injury, these are all elevated on the first clinical visit for atrial fibrillation in Utah. And it's not to the magnitude we see with concussions, but they're all elevated. So we know that injury occurs early. What we know as well is that our response to the injury, as we form antibodies to these proteins, also augments cognitive decline and dysfunction. So it occurs early, and how we respond are important in this. And this is starting to become more paramount and more understood throughout the world. This was a Swiss atrial fibrillation study, and I was really interested in this early on. I reviewed this for their equivalent of the NIH. And of course, I told them I was biased, but I wanted them to do it. And they took people with atrial fibrillation and they were enrolled and they got a screening MRI. These were just all comers, and there were 1,700. And on their screening MRI, you can see that 20% of them had a small non-cortical infarct, large non-cortical infarct, microbleeds. And interesting enough, almost 99% had white matter disease. And independent of these different injury patterns, when they performed cognitive testing using MOCA or general well-being testing, these injuries were associated with cognitive decline and deficit. And this led them to say, well, the clinical strokes, which we've used for years to understand the impact of brain health on atrial fibrillation, is the top of the iceberg. And all these other things underlying it lead to cognitive decline and dysfunction. And they went on to study these people and do another MRI at 2 years. What they found was that there was a doubling of brain injuries from what we thought occurred just using clinical symptoms. And when you consider traditional strokes with traditional symptoms, they're associated with deficiencies in cognitive operations, memory, language production, mental flexibility, et cetera. But when you take non-traditional clinical strokes, the one we picked up on an MRI 2 years later, they had the same defect. And it brings up this concept: is clinical stroke significantly underestimates the incidence, but also is silent strokes a misnomer because we're not using the right probes to understand. And again, this just gets to the impact of atrial fibrillation on the brain over time. And this all came about for me with a single patient. This isn't his picture, but this is his rhythm. When I saw him in clinic, but I first saw him in the hospital. And in the hospital, we have a monitor, and you can see the monitor right above the patient. And the patient was a salesman, and he had all these stories. So it's hard to get his history and physical done because he had all these stories. So he'd be sharing this story in sinus rhythm, and he would go into atrial fibrillation. It was a little bit fast at the time. And then he would just stop speaking, and his wife, who had heard the stories a million times, would just fill in. And then he would pop back into sinus rhythm, and he'd say, whoa, I had a senior moment, and he would start on again. And that happened over and over in this clinical exam. And it brought up the question, well, is atrial fibrillation associated with different forms of cognitive decline that we had seen before and thought of before? Because we'd often thought of vascular dementia or multi-infarct dementia. But what caused this transient dysfunction in this patient? So we did this study, and we took neurology codes throughout Utah, and where they coded patients for nonspecific dementia, Alzheimer's, senile, and vascular. And we took patients with atrial fibrillation and without. And you could see there was almost a doubling of risk of these idiopathic dementias. And we knew this was going to be present. But surprising was the fact that it was associated with idiopathic dementia. And it was interesting. We presented this at the Heart Rhythm Society, and it received a lot of press throughout the US and world. And the next day, we had hundreds of emails of people whose parents had dementia. They were just diagnosed with atrial fibrillation, and they were concerned of their risk. And our first concern with this was, well, we're looking at two diseases of aging. And in fact, the New York Times brought that up in an interview. They're like, well, you're just putting two diseases with aging together, or you're just missing stroke. And what was interesting is we explored this further was the relative risk of dementia and cognitive decline was in the youngest patients. It was actually the younger patients with atrial fibrillation, and this wanes over time. So we thought we were seeing something more than an epiphenomenon, and it gave us reason to continue to kind of explore this hypothesis. And the group at Rotterdam found the same thing here in this study. And they found the relative risk of cognitive decline was actually in our younger patients with atrial fibrillation, and it wanes with time, where vascular dementia tends to increase with time. And they went on to expand our findings by showing not only is it the younger patients, but it was the younger patients that spent more years in atrial fibrillation and often sometimes undertreated because they're thought to be of lower risk. And this recent meta-analysis showed that almost all of the studies are identifying younger patients with atrial fibrillation being those at higher risk, with the outliers, these groups of which it's under 55. And I think they may be too young, but they're also underrepresented in most trials. And they do often represent a different type of atrial fibrillation patient, the really young one. So a lot of people are finding that. And what can explain that? We know that atrial fibrillation, there's a lifetime risk of 20 to 40%. We know in dementia, it's 1 in 5 in men and 1 in 6 in women. And this is increasing particularly in westernized countries. So what could explain the fact that we're seeing more dementia in our younger atrial fibrillation patients compared to our older patients? And well, of course, our first thought is this can be a survival bias, because the combined state is often a deathly state. And in my hometown of Logan, Utah, John Hopkins has been running a study in an Alzheimer's ward for about 40 years. I had no idea this even existed. But one of their first studies when they were looking at outcomes of Alzheimer's disease was to say when people got atrial fibrillation, they died within 6 months. And it's just been part of the known literature, but really not understood or picked up upon until recently. Perhaps the brain begins to have dysregulation and maladaptation early, and we see this in younger patients. We do think delays of anticoagulation are critical, and I'll talk about that a little bit and the data support that. Also, younger patients return to work, and perhaps their symptoms are more manifest, where older on they may not be. And it also brings up genetic risk, and is there an association? And it's a double hit phenomenon. And speaking of genetic risk, we do know in the community there are diseases associated with high risk of dementia, particularly ApoE, and puts you at high risk. We see a lot of people with this now, and in our clinic with some of these data, they say, well, I did 23andMe and I have dementia risk, now I have atrial fibrillation, and what can I do? And we have this study, which is, I think, fascinating. It's been submitted, it's in revision with CERC A&E. But if you take PET scans of people that have Alzheimer's disease, and you take PET scans of people with atrial fibrillation, and you compare them to normal, what we find is the changes of metabolic activity are completely different in Alzheimer's disease versus atrial fibrillation, and the dysfunction appears to be different. And that's not surprising. Years ago, we looked at genetic markers of atrial fibrillation and Alzheimer's disease, and we couldn't find an association between ApoE and atrial fibrillation. They did not appear to be synergistic. And so we thought that perhaps there were different mechanisms explaining this. The associations we found in genetics were related to those patients that had early onset AFib, PITX2, or Zephyr, in which they also have a thrombotic tendency. But this recent data has put metabolic activity saying these are different pathways. And so there's more to come in this. And there's also a fascinating paper on how our body returns or recycles. And that's impaired in people with dementia. And when we look at people with atrial fibrillation, the impairment's in a different area as well. So there is opportunity for both disease states to perform improved brain health, but it may be through different pathways. So I set this up a while ago as we considered opportunities not only to look for risk, but also as potential therapies. One pathway being the injury is due to micro-macro bleeds, which is well described. This breaks down the blood-brain barrier, leads to cellular loss. Another is related to hypoperfusion, capillary hypertension, arterial hypotension, blood breakdown of cells, volume loss, and there's numerous mediators. We talked about genetic risk, vascular disease, oxidative stress, inflammation. But on this upper pathway, if true, then perhaps the timing, use, and efficacy of anticoagulation is critical. On the lower pathway, then rhythm rate, cerebral perfusion strategies may impact risk. Let's start at this upper one, the more commonly described pathway, and explore some of the data behind it. This data from the Swiss registry showing patients that were treated with oral anticoagulation at baseline versus not. you can see an early separation in risk of dementia compared to those not treated. And this second pathway is effective versus non-effective oral anticoagulation. And if anticoagulation became effective, and their effective was 40 to 80% over time, which is not uncommon in these registration studies, but you can see that anticoagulation used did impact risk of dementia in patients. But I found what was interesting, the most interesting in this study is the multivariate analysis where timing was so critical. If you started early, 0 to 1 years, it was highly effective, and then it started to wane. And if you waited 3 to 5 years, then there was almost no benefit at all with anticoagulation, and gets to that Rotterdam study of young people not anticoagulated for multiple years being at higher risk. And we found the same thing in Utah, looking at warfarin at the time. If it was started early on, dementia rates were very low, and as it was delayed, there was sort of a linear increase over time. So I think onset, use of anticoagulation early is critical. We have a new opportunity to move this even further as self-diagnosis of atrial fibrillation is becoming quite common with wearables. The next step was, what about effective anticoagulation? And these are people that came in for warfarin anticoagulation with atrial fibrillation, and they were screened at the time by our community pharmacy anticoagulation service to be mentally competent and pristine. And we take those patients that are normal at baseline and then look over time based on their time and therapeutic range. You can see a linear decrease in people that once were cognitively healthy based purely on the fact that their anticoagulation efficacy. I think efficacy is critical as well. What's interesting in that population, the patients that are at the highest risk for high versus low anticoagulation efficacy were in the younger patients with atrial fibrillation compared to the older patients. So this group appeared to be more vulnerable, and it may be the fact that they're living for a longer time with ineffective anticoagulation. And there's a lot of data on the role of bleeding in particular, and it's driven by a number of different causes. But what's interesting on the epidemiology standpoint is risk of microbleeds is increasing in our community. And this is age both dependent and independent, driven by a lot of cardiovascular comorbidity that causes these vascular changes in the brain to be predispose it to more risk of bleeding. And the time you spend over anticoagulated is also critical. So if it's 10% versus 10 to 25 or over 25, getting people that perform normally on cognitive testing at about 5 years, you can see that there's a significant difference in the risk of dementia. And this is clinical diagnosis of dementia at that time. So we ultimately said, well, is it the atrial fibrillation at all, or is it just the anticoagulation? So we took a large group of people that were anticoagulated for other causes without atrial fibrillation. And in this group, there may be some subclinical atrial fibrillation. But we saw the same pattern. The worse your anticoagulation was over time, the higher your risk of brain dysfunction and dementia. But atrial fibrillation was additive. It augmented the risk in every category. So there's more to the rhythm and the risk in the brain outside of anticoagulation. So this brings up the natural question of, well, we don't really use warfarin a lot outside of valvular heart disease. What about newer anticoagulants? So we looked at this early on in the community, and we found that stroke rates with the new or direct oral anticoagulants were better than warfarin. And in the community, there was actually lower dementia. And of the different anticoagulants, dabigatran seemed to have a preferential reduction in dementia compared to the others. And there's some mechanistic reason for that. But we were able to see that in an observational setting. And we're seeing this in numerous studies as well. And this is one illustration of the Korean healthcare system. There's some from Taiwan, there's some from China, there's some from Europe. And they show, compared to warfarin, all of the newer anticoagulants in the community are associated with lower rates of dementia. They're more effective. When compliance is not an issue or cost, they tend to be associated with lower rates of brain injury. So what was missing was randomized controlled data. And we've gone after this as well as the group from Brazil. And these are 200 patients randomized to dabigatran versus warfarin. Again, dabigatran had early markers that it may be lower risk. And they found that the risks were actually quite similar. In fact, if anything, on the MOCA study, the patients on warfarin performed better. What was interesting in the one area where dabigatran did better was memory. And even though they were similar, that was the one domain that was better. We performed what was called the cognitive atrial fibrillation trial, randomizing as well, but we did brain imaging as well, and we did serial biomarkers to understand the role of the antithrombotic agents. And in every score that we used, there was no difference between the two agents at all. And the brain scans looked similar as far as subclinical strokes, atrophy, volumetric assessments, they were similar. But what we found, and this is a little bit busy, but the important thing is of all these aspects of antithrombotic therapy and efficacy, there was not one that was different. And this gets at some of the challenges with randomized controlled trials. These patients were different. They responded very well. They were treated very well. So if you have somebody on effective warfarin, we don't really have a reason to change them. And that shows that here. But if they're not effective on warfarin, I think there's compelling data and they're willing to be adherent and compliant with novel agents, then there's reason to switch them. There's a lot of excitement about appendage closure devices. There's a lot of them, commercially approved. But what's important with these is if you look at rates of stroke, they're always higher in these trials compared to long-term anticoagulation, and that's just clinical stroke. There really has not been a study done on looking at micro strokes, looking at cognitive function. The one small study that has been done, patients' cognitive function did not change after Watchman, but it went down in the anticoagulation group, which we haven't seen in any other trial. So I think it needs to be done in a larger study that's populated. But that's the biggest concern, that the Watchman device does increase risk of ischemic stroke offset by bleeding stroke. And we really have no idea on the small vessels or small clots in the brain. What we do know is appendage occlusion may have a role. This is the Laos 4 trial. You could see as far as incidence of stroke with occlusion versus no occlusion, for the first time, complete stroke rates went down in the surgical population, where it's never gone down with Watchman or Amulet or any of the other device. And some of the clues of this is the fact that these patients were kept on anticoagulation. In fact, 80% of them are. And that's actually a high number for even an anticoagulation trial to maintain on anticoagulants. So they did a great job continuing anticoagulation. As mentioned, for the first time, ischemic stroke with appendage management was lowered. There's now the Laos 4 trial, which is a Watchman trial with a lower dose of anticoagulation. I was excited to see that trial get launched. I was trying to get Boston to do it for about 15 years, and they're finally doing it, because even with the best management of the appendage, we're still leaving 10% of atrial thrombus untreated for, and that needs to be treated with something. What with that something is still needs to be studied, whether it's an antiplatelet or a lower dose anticoagulant or a full dose anticoagulant. We just don't know yet. So that kind of talks about this upper strategy. We know that we believe the timing's important, the use is important, and the efficacy is critical to help in this upper pathway. And I think it makes sense because we have the chronic thromboembolism model as one to reflect upon and see throughout history as something that can influence brain health. Well, let's kind of move down to this one, where some of the things may not be quite as intuitive. And again, think about this patient I saw initially. There's times in the day that he's fast. There's times he's relatively controlled. And there's times at night where he's profoundly bradycardic. And on a microvascular level, these things can all be important, and they can lead, if the body cannot compensate, to in-organ dysfunction. And this is not an uncommon tracing in somebody with atrial fibrillation. When we see them in clinic, we see a spot check, but on a 24-hour monitor, this is not uncommon. And when modeled, this is what it looks like. Typically, if you have normal perfusion, 90% of the time or plus, you're in this healthy pressure range, and 5% it may be low and 5% it's high. But when you go into atrial fibrillation, you can see this is completely shifted leftward. And you have almost 30% of the time you're hypotensive on the microvascular level, 9 to 10% you're hypertensive, and then you're 60% in this normal perfusion range. And more recent data this year has really focused on that and now using human data of the time in which you're more bradycardic. And when you're very bradycardic with these long RR intervals, there's a drop in blood pressure on the mean of 13.7. You actually get a decrease in oxygenation and blood volume into the brain when you're in these lower areas of time, which again is about 20 to 30% of the time in patients with atrial fibrillation. And one of the things we see in a hallmark with atrial fibrillation, again, is this white matter disease. And in fact, 99% of people on their first brain scan with atrial fibrillation have this, and we see it all the time. And what does it mean in patients with atrial fibrillation? Well, one of the aspects of the brain that I think is really interesting is these lenticular striate vessels, and they come off quite oblique or perpendicular to the cerebral arteries. And when you take people in atrial fibrillation, whether they're slow or fast, again, slow being over here, you can see the perfusion changes between normal and atrial fibrillation. And these vessels, because of their unique orientation, are uniquely vulnerable to that. In fact, they begin to break down at these takeoff points, and that activates oxidative stress and atherosclerosis from the rhythm alone and the low pulse perfusion. This is seen in the community as well. If you take people with persistent atrial fibrillation and you look at, so these aren't your athletes. One time I was asked that, these aren't your super athletic people. These are just general atrial fibrillation patients. If you break them down by their average heart rate, over 100, 80 to 90, or less than 60, 60 to 70, you can see as the heart rate got lower on average, the risk of dementia in previously cognitively healthy people went down. And I think in our receiver operator curve where this broke and separated people at risk and not was 72. There's really interesting community data on what an average heart rate is in the community. In women, in men, it's 70 to 80, but in women, it's 75 to 85. That's sort of the normal range. And oftentimes with atrial fibrillation patients, we sort of want them to look normal. And so we push their heart rate to look normal, but that may be harmful on organ health. There's some critical gaps in knowledge. We don't know if there is a role of pacing to prevent these long RR intervals. Again, we're cutting at about 72 beats per minute is where there appears to be a decline. And we don't know the role of physiologic pacing. We now have pacing that can actually really replicate, because of our ventricular synchrony, normal perfusion. And we don't know the role of more lenient rate control strategies, particularly in the heart failure preserved EF community. There's a really interesting study by Medtronic taking people with heart failure preserved EF that weren't traditional candidates for pacing and pacing them so you can compensate. And they're not doing cognitive testing. They're interested in that, and it may be added. These aren't atrial fibrillation patients, but getting at this notion of should we be raising heart rate to help with compensation, where previously with, of course, restrictive physiology, we were allowing the RR intervals to be really long. There's one study that's examined this a little bit, and this was using CT perfusion of the brain. And this is the frontal lobes, infrafrontal and lateral. And you can see an atrial fibrillation that's lower compared to sinus rhythm. And then they AV node ablated these people and they normalize. So we do have some data when you do an AV node ablation and check CT volume perfusion that you can normalize some of the deficit early on, or some of the deficit seen before that procedure. So this is a study we wanted to do, and we wanted to understand, does brain adaptation change in atrial fibrillation? So we took a dog model, pace-induced atrial fibrillation. The dog is actually a great model to study the brain in. Often in EP, we think of the heart, and we can put it in atrial fibrillation, and the dogs over time don't get huge like pigs do, and they don't fibrillate like pigs do. But for brain health, it's outstanding because they have this network in their neck, and it captures clots. It's used for ventilation and to help with heating, but it actually, from a research standpoint, you can study brain health without strokes. And what we did was we took dogs at baseline, and then we gave them Diamox to test what type of cerebral vascular reserve they have at baseline. And this is a normal response. It almost goes up 60% when you cause cerebral vascular dilation compared to baseline. We wanted to see how atrial fibrillation impacted that. And what we found was a normal response. Here's gray matter perfusion and white matter perfusion. And we gave them Diamox. You can see this significant improvement. What's fascinating to me, at 3 months, independent of stroke, their response was completely maladaptive in atrial fibrillation. And over 6 months, it started to improve, but never became adaptive. It was still maladaptive. And we know a lot of patients with atrial fibrillation that they go into atrial fibrillation like, I don't process right, I don't feel right. And it tends to wane over time, those symptoms, but they don't quite get back to normal. And I think this is animal data to kind of show that. And these, again, are healthy animals without strokes, just looking at how the brain adapts to being exposed to atrial fibrillation. There's human correlates with this. This is if you hold your breath, CO2 reactivity, and then you measure brain perfusion. And in healthy controls, it goes up. In hypertensive patients, it goes up. But atrial fibrillation patients, it goes up less. And if you further take those patients, those that are paroxysmal versus persistence, that adaptation is even less. And the autonomic dysfunction seen just from the presence of atrial fibrillation in patients without stroke, there's about a 30% lower response to breath holding just due to atrial fibrillation, and compared to patients that were healthy or had hypertensive disease without atrial fibrillation. But as you can imagine, and they went on to study atrial fibrillation plus atrial fibrillation with hypertension, saying does additional cerebral vascular risk or impact compensation further, and did CO2 inhalation looking at brain volume imaging, and found that if you have the combination of the two, it starts to go down further. So atrial fibrillation impacts brain autonomic compensation. And when you're predisposed with cerebral vascular disease, it is worse as well. So we have evidence to suggest that the brains are exposed to injury patterns. We see early dysfunction of the brain and inability to compensate. And we know that white matter disease is a marker not only of vascular disease of the body, but it's also a marker of a predisposition to vascular stress of the lenticulostriate vessels. So what can we do about it? Is going back to that diagram, is our rhythm strategies helpful? And there is some evidence for rhythm control. And this was a study in which they looked at brain perfusion before and after cardioversion. And compared to healthy controls in sinus rhythm, patients in atrial fibrillation had less perfusion in their gray matter, whole brain, and in total. And this is sort of what it looks like. This is somebody in atrial fibrillation, and after a successful cardioversion, you can see the significant improvement in brain flow. And think about this, the brain, our body is designed to protect the brain. So the brain is your best example of how you're going to compensate in atrial fibrillation. You can see the significant improvement in restoring sinus rhythm. And here's somebody that did not cardiovert, and you can see no change at all. And in all the areas of the brain studied, in those that cardioverted to sinus rhythm, there was an improvement in vascular flow. We looked at this a little bit in the Cabana study. We had to use stroke, but we were interested in what it means to be in sinus rhythm. And this was it's our largest study of patients randomized to ablation versus rhythm control. And they were followed for 5 years with these cabana monitors. So we really were able to, have to sort of look at the study. We had to sort of define what sinus rhythm means over 5 years, because people can have short runs of fibrillation but spend most of the time in sinus rhythm. But if you are in sinus rhythm, mortality was lowered, and this primary endpoint, both adjusted and unadjusted, was lowered. And I'll go through that endpoint here, because this is what we saw with sinus rhythm as a target. There was lower death, cardiac arrest, disabling stroke, and bleeding. And again, a 41% lower risk of death. So when you're in sinus rhythm, independent of the therapy, so effective medications or effective ablation, you could significantly impact brain health in 2 ways, by impacting bleeding as well as strokes. And this is another study that showed the advantage of rhythm control versus rate control. This is the East AFnet trial. And for the first time, rhythm control won. We have these older studies that said no. And what was different in this study was they were randomized within 1 year of atrial fibrillation onset, where in AFIRM and CHF and others, patients came in at different times. But their composite endpoint, including stroke, was reduced with early rhythm control. And they went on to look at this further, and it wasn't just early rhythm control that was helpful. It was carried predominantly by sinus rhythm. So the patients that did well in this study weren't necessarily those treated with early rhythm control. It was those treated with early rhythm control that maintained sinus rhythm. So similar to ours, I think sinus rhythm, if we're going to improve stroke, can be a target to go after. There's a lot of studies looking at, if the amount of sinus rhythm you're in, the burden of fibrillation, can those be used to guide decisions of anticoagulation? I don't think we have data to support that right now. So I tend to advocate use of anticoagulation based on CHAD score, but there is some compelling data on the role of sinus rhythm as a therapeutic target. And what I also found really interesting in this study was the fact that, it was good. Thought I had that in this set, was the fact that patients that were symptomatic or asymptomatic, about 40% of the population of East AFnet were asymptomatic at the time of enrollment. And those patients did as well as those patients that were symptomatic. Let me check really quick, just to make sure I have the wrong side set. Oh, I do. Sorry about that. So I kind of want to get into this asymptomatic study really quickly. This is data, brain perfusion data on the role of catheter ablation. These patients had brain MRIs at baseline at 6 months, and compared to healthy control patients, brain perfusion was worse in those with atrial fibrillation. And when they went on to understand after an ablation, patients got better, but it was mainly in those patients that had non-paroxysmal atrial fibrillation. Those patients that were more often in persistent in abnormal rhythm compared to those that would come and go. Early data we did looking at the role of ablation in risk of stroke and brain health. We were interested in this population, atrial fibrillation ablation patients, a little bit interested in the atrial fibrillation no ablation population, but we knew this was a biased population, the group that goes on to be referred for an ablation, and you can see that in the differences in demographics. But we were very interested in how this group, after an ablation, did compared to patients that never had atrial fibrillation. And in this curve, you can see those without atrial fibrillation versus those with atrial fibrillation without an ablation. And it's not surprising these groups did worse. But what was interesting was those that underwent an ablation, as far as stroke risk across Utah, had similar events to those patients that didn't have atrial fibrillation at all. And the dementia rates followed this same pattern, whether it was Alzheimer's disease or other dementias in general, that the patients that underwent an ablation were similar to those without atrial fibrillation. And there's selection with this, there's patient motivation, but we can take advantage of some of that in identifying those patients that may preferentially benefit from more aggressive therapies. We did this work with Emily Zietler up at Dartmouth and looked at the claims data, finding the same thing, catheter ablation versus antiarrhythmic drugs throughout the US. There were lower rates of dementia. And this study was large enough that we could look particularly at women. Again, they're at higher risk of Alzheimer's disease, almost twice what men are. And we could see the same pattern in women that we see with men. Is timing important? This was mimicking the EAST-AF-NET trial, but specifically looking at the role of catheter ablation and dementia. And if you take people within the first year of atrial fibrillation and they're randomized to an aggressive rhythm control strategy, all dementia is reduced by 17%, Alzheimer's disease by 17%, and vascular dementia by 20%. And we know injury occurs early, and we're getting compelling data to say how we treat people early on is important to improve their risk. This is the most well-done mechanistic study looking at the role of catheter ablation, and they performed the MOCA testing in a control group versus an atrial fibrillation group. And they did it at baseline, 3 months, and 1 year, and independent of prior cognitive impairment, older, younger age, anticoagulation, paroxysmal versus persistent atrial fibrillation, warfarin versus DOAC therapy. Patients that had an ablation did better at 3 months and 1 year. And what I found the most interesting in this trial, again, looking at perfusion deficits in the infratemporal lobes, microvascular risk in the infratemporal lobes, is the cognitive domain that these patients did better with that underwent an ablation was over here in memory. And again, that's the area where DOACs showed the greatest benefit. Ablation shows the greatest benefit and is often the hallmark of early dementia. So again, I mentioned this. This was that EAST-AF-NET looking at patients that were asymptomatic at baseline versus symptomatic. We see similar patterns of benefit at early rhythm control, but this gives you some of the numbers of what would be classified as asymptomatic versus symptomatic in that group. And the question is, should we reevaluate the asymptomatic label? When we've studied in Utah, you get a disease-specific patient-reported outcome battery with any clinical visit. So atrial fibrillation patients get sent atrial fibrillation symptom scores. And if you take people, there's significant gender differences, age differences, and demographic differences of who reports traditional AF symptom scores. And some people, and these are patients that had atrial fibrillation on corresponding monitor or EKG, and this was the frequency in which they reported traditional symptoms. And this is the multivariate analysis showing more likely to report traditional scores versus less likely. And of course, as we get older, it becomes less likely that we report traditional scores. You know, you may not have shortness of breath going up a few flights of stairs, but you may have other symptoms. And recently, Australia looked at what were the most common symptoms in the elderly. And not surprising, fatigue was number one, but number two was depression. And I never ask my older patients with atrial fibrillation, when they say I don't have any symptoms, do you feel more depressed? Do you feel more mood disturbances? And depression is critical. And this is data that we have in submission, but looking at the role of depression, if you take people with atrial fibrillation that report depression, you can see the risk of dementia is much higher at 3 years, 5 years, long term. And there's a lot of data in the dementia literature saying that depression is a first symptom of dementia, but it's probably more complex than that. And I started asking that with my patients. And often you ask the spouse or significant other, and they'll bring out the symptoms that are of interest in this area. But even when we do landmark analysis, trying to look at other comorbidities that may associate with depression, the risk is still significant and real, and these represent a higher risk population. So what can we do to further risk stratify who may benefit? We've been trying to use AI, and we've used common markers of health. So we'll look at the blood count We'll look at the basic metabolic profile, and then we'll add that to the CHADS-VASc score. And you can see across multiple CHADS-VASc scores characterizing people at low, medium, or high risk that we can use simple blood tests to predict patients that may be at higher risk of dementia over time with atrial fibrillation. And again, in these populations, we're trying to get people the best we can that are cognitively intact, knowing there's some limitations. But you can see in almost all domains, we're able to risk stratify further. The question too with this, can we use it in people that engage in risk factor modification, lifestyle changes? Can we use it the other way? And what I find really fascinating is if you take red blood cells in a normal distribution, blood cells can be unhealthy or suggest systemic disease when they're big and small. And you can quantify that in patterns, and using AI can see these patterns in different categories. Are they all small? Are they all large? Are they broad and heterogeneous? But as you look at the blood cells alone in atrial fibrillation patients, you can predict in a quite interesting manner which patients will go on to get atrial fibrillation and which won't. And I think that's really interesting. And again, suggests that we may have an opportunity to augment our understanding using dynamic tests as we get more and more processing data to help us out. So I'm going to wrap up here just saying that this isn't just the brain. And as I started this talk, we talked about how atrial fibrillation patients do poorly from a whole standpoint. Their muscles, their respiratory system, their immunity, their general ability to thrive. If we look at macular degeneration, dry macular degeneration, adjust for all comorbidities, patients with atrial fibrillation have more macular degeneration. You adjust for traditional risk factors for diabetes onset, and you can see patients with atrial fibrillation have more diabetes and pancreatic dysfunction. And this brings up a lot of intriguing questions on some of our new heart failure medications that may also protect against diabetes. Can they be used in patients with atrial fibrillation? And kidney dysfunction as well. Patients with atrial fibrillation's creatinines tend to increase over time, and more of them are diagnosed with atrial fibrillation or renal failure compared to those that aren't. And that's that same study where we looked at that large population comparing to those without atrial fibrillation. So the more organs we look at, the more we start to see are impacted by atrial fibrillation. And there's also interesting data, again, on mood and perspective and energy and activity in our patients with atrial fibrillation. So in summary, atrial fibrillation, stroke, dementia, and brain health. What we know that atrial fibrillation impacts brain perfusion, vascular function, adaptation, and autoregulation in a stroke dependent, which has been well described, and now recently independent manner. Patients with atrial fibrillation exposed to slow rates and prolonged RR intervals do represent a higher risk population. And there are critical knowledge gaps in this population regarding the role of potential therapies we have at our disposal right now. And I think finally we're getting some stakeholders to engage in this discussion so we can start to study it in a prospective manner. Sinus rhythm, I believe, is a therapeutic target. And it does represent a healthier person, and it can be used to improve outcomes in patients with atrial fibrillation. And I don't have in this talk, but what does it mean to be in sinus rhythm is an interesting discussion. It's a complete grand rounds in itself. But sinus rhythm in general is a therapeutic target. And effective rhythm control may improve brain function and lower risk of brain injury when used early with comprehensive medical management. And the one thing I didn't talk, and it's central to all of our guidelines, is the role of risk factor modification, comprehensive medical management. As this affects the body as a whole, our therapy won't be singular ultimately to improve the quantity and quality of life of these patients. Thank you very much. Yes. Yeah.
This is a really compelling argument for more aggressive restoration of sinus rhythm and anticoagulation. A couple of areas that you didn't address: sleep apnea, which is so frequent in this population. I wonder how much, especially at nighttime, causes that may play a role. And the second thing is, it's interesting, the over control of rate, how that may have adverse effects. But how much of that is from more variability in the heart rate? Because at slower rates, you're going to see more variability than at more moderate rates.
Yeah. Both really good questions. The first on sleep apnea, there's clear evidence that sleep apnea independently impacts cognition. And to separate it from fibrillation, particularly in the community setting, is hard. And so I think it's hard to say the relative contributions to each. I know the biggest challenge with CPAP therapy is it just hasn't improved outcomes with atrial fibrillation like we want. And I don't think it's necessarily that the hypothesis is wrong. We just don't have a good therapy that people tolerate. And as we get more physiologic pacing or physiologic breathing, perhaps we can improve it. But I think I treat them connectively. At Intermountain Healthcare, I was the #1 referrer for sleep apnea for over a decade. And I look at it, even in my healthy people. And it's interesting, even endurance athletes with atrial fibrillation, I see a lot of those from Park City, and about 20 to 30% of them have sleep apnea, and they look like they could be on Runner's World. And so I screen everybody. But it's a great question that we still don't know a clear answer. The variability is a good question, and that's sort of the next step. We've looked at length, but nobody's really looked at variability. Of course, with sleep apnea too, you can get an elevation in sympathetic tone that can minimize variability as well. It would be something really interesting to control for. We do have some aggressive sleep apnea folks at our institution, but they're interested in all these device therapies, and I'm not sure if those work. I haven't seen them improve arrhythmia burden like we had hoped, like these Inspire devices. And so, but they're really enthusiastic because they just haven't had anything for central sleep apnea for a while. But yeah, great questions and things I don't know yet for sure. Yeah, go ahead.
Just one question, one statement. Fascinating subject, brings up a point for me. I don't really know how to address this patient. And having trouble developing a coherent message about really addressing that down the road. And I know that's not something to spend an hour talking to us about it. I guess the one question I had is, brings up a point of the underuse of a late pace lately with so much focus on rhythm control. You have a lot of these older patients who were kind of cared from other conditions for years. We are somehow still a little reluctant to use late pace. And I wonder whether some of the cognitive improvements and improvements in depression scores that you showed are not so much from increase in nighttime bradycardia, but massive doses of beta blockers for 30 years. Not been studied. Some of the studies were what happened to the rate. I know what happened to the rate of agents, but is it controlled?
Yeah, that's a great question. And we looked at that at our data on heart rate in people that were normal, looking at those that were managed with medication versus not. And we saw a similar trend. But that's the only study. What's interesting is your exact thoughts is a formation of a large Canadian trial, and they're doing it with like Saudi Arabia and Singapore. This is a multi-country study, but they're looking at the role of ablatant pace earlier and trying to improve. And it's a study designed for heart failure, secondary, some of the brain, because we now have better physiologic pacing tools, and there's not as much detriment and risk of going on to get pacing-mediated cardiomyopathy. So I think that is actually a trial that it's been submitted. They're looking for an industry partner, and there's a few industry partners that are looking to jump into this trial or design their own. So I think there will be at least one, but there may be 2 or 3 trials that actually look at that. And if you work with neurologists, I do, they're always interested in lowering beta blockers and blood pressure. They want more perfusion. And so they've long known that hypotension is important in the role of these medications on these poor outcomes. Now, people that are older and as they begin to develop cognitive decline, use these medicines less. So we want to say, can we do it in a more preventative therapy? On the rhythm side, though, we're now ablating people with pulse field ablation that were sicker. So on the other side, because there's a very rapid tool for ablation that appears to be similar in effect and can be done, at a third of the time, sicker patients are now getting enrolled in are getting ablation. I didn't show, we do have, when you take people with cerebral vascular disease, carotid disease, or vertebral disease, they preferentially do better with ablation because they can adapt. Will those patients do better because we now can offer ablation with perhaps not using anesthesia or keeping them under very long. So I think there's things that push us towards ablating pace earlier, but we now have newer ablation technologies that are also pushing ablation early. We're sort of separating, like coming into Boston this morning, there's one road and it just separated. And people believe firmly in both arms right now, and that time will tell which would be better. Yes, go ahead, Peter.
I think you deserve a lot of credit for raising this issue in the first place. It seems to me like such a complicated area to study, though. Why do you we can start treating systolic hypertension. And certainly can start treating hyperlipidemia in that majority of other agents that we think of having a significant effect both on primary development and actually having cognitive function that maybe at this point we're going to use that static recommendation around those things. Have you seen, is your sense that we're going to be vary?
Yeah, I think that there's a lot of truth to that we've been slow to adapt. Like the NIH Sprint trial is well known to support aggressive rhythm control or blood pressure control. The lesser known is the Sprint Mind trial that ran in a contemporary manner and showed that aggressive blood pressure management does improve cognition. And what I'm optimistic about is all the guidelines now orienting around risk factor modification, the European guidelines and the US guidelines. And then also there's a lot of interest, at least at the Heart Rhythm Society, and what does it mean to be a center of excellence for atrial fibrillation? And all of those discussions, again, don't center around ablation, which a lot of the EPs want to do all the time, and I'm one of those. But they center around how are we managing this patient with risk factor modification. And the patient advocacy groups are interested in that as well. So I think there's those compelling interests, the guidelines driving, best practices. Societies interested in getting best practices to their patients, now embracing risk factor modification, and then the patients themselves being able to track themselves, being able to track their health, and getting these things that internally motivate them. I think those things will all help. But to your point, all these things. This is I have this slide I didn't show, but this is looking in Europe compliance to DOAC therapies, and you can see even when they're available to you, keeping people motivated is critical. And if people aren't engaged and aren't continuously engaged, we lose opportunities to keep them healthy long term. So yeah, I think it's a great comment and something that's where we have to go to improve health. Oh yeah, go ahead.
I have two questions. One is that factors with the outline. So I don't perfect variability, low heart rate, status, relative contribution. The second question is any of these findings of structural or functional given an antibiotic
Yeah, the first question is easier. When you take the same Holter monitoring in Utah and you look at dense PVCs, which we termed over 20%, or dense PACs over 15%, you can see a similar pattern. Not as the event rates are lower, but similar pattern. So there is some of that. But it hasn't been studied in a forward manner just because some of the challenges with variability of ectopy over time. But people like Mintu Trocula he's now over Zio is really interested in that. And then of course Mayo is interested because they've integrated all their EKG into their neural networks and studying it. So I think there'll be some interesting things. It's almost a stepwise approach. Age outstrips everything, as you'd imagine. But this is actually this is from the ERIC registry. And it gives you a sense, and this is looking at Alzheimer's disease, vascular disease, and looking at Chad's VAS score, sort of an incremental matter. And what they found, looking at mild cognitive impairment and dementia, you can kind of see that it's all over the place to identify one thing. Again, age is high. We're talking about not stroke independent dementia here, but obviously we know that stroke causes dementia, but they're looking at heart rate as well, proBNP, troponin, and people that have underlying ApoE. This is a little misleading because it's just the presence of ApoE. We know that doubles in the community. And we didn't see that AFib added to that, but we know if you do have ApoE, you do have a higher risk of dementia. But that gives you probably the best data in a large data set at trying to understand weighting of variables.
Very much interesting. I think our lack of success in predicting against stroke does well with our intervention that underlies.
Oh yeah.
The lack of, first of all, how heterogeneous 3 years some actually progress and varying stroke risk. Certainly a lot of these people, I think, are mutations. Eventually, it looks like AF, but it's really a
yeah.
And have excessively high stroke. So probably are phenotypes and genotypes. Hopefully, characterize patients outside of all the things we've been looking at.
Oh yeah.
30 years.
We're hoping to do some of that. In Utah, we have the population health database. There's 3 interesting databases in Utah. And then we have this whole group with genome-wide sequencing. But Utah also, because there's a lot of these big families, multi-generational families, we have this genealogy database. And we've just put together some of the funding to merge those. And it'll be interesting to see because there's variable penetrance, but Peter knows where he's looking at the PR or the P wave morphology duration for atrial myopathy. It predicts stroke, and there's a lot of things that we can now do with processing power that are really interesting. But we're hoping to get some of that multi-generational data to as soon as we can. It's just we had it all in place, and then like anything with AI, there's outside of academics, a lot better paying jobs. And so as soon as we had everything in place, our lead guy was, went to one of the large social media groups. And good for him. You got a lot more money, but yeah, we're in the hiring. So if you know of a good person, let me know. We're back hiring again. All right. Thank you.